At times, your visualization may be obscured by fogging. Fogging occurs because of a temperature differential between the blade assembly, which is in the cold operating room, and the patient, which is at body temperature. That condensation can cause fogging on the camera tip, which then obscures your vision. There are several things you can do to mitigate fogging. The first is to use an anti-fog solution. One can place the anti-fog solution on a cloth, simply withdrawing the camera from the blade assembly and placing defog on the tip of the camera will wipe the camera clean and add a layer of protection against further fogging. The camera can then be reinserted back into the blade assembly. An alternate method for helping with fogging is to raise the temperature of the camera and blade assembly more towards room temperature. This can be accomplished by taking the camera, and sometimes even the camera and the blade assembly in its entirety, and placing it in a warm saline solution. The lighthouse to the appropriate planes for the ECTR is the Palmaris Longus. Now, as you'll notice, sometimes the Palmaris Longus is difficult to assess in a patient when they're asleep. However, it is often fairly easy to be able to find the Palmaris Longus actively in the preoperative area. Often I will have my patients demonstrate to me their Palmaris Longus actively in the preoperative holding area when I mark the patient. In that case, I will then dot their Palmaris Longus when I initial the patient. This allows me to know where the Palmaris Longus is when I get to the operating room. Just as the Palmaris Longus helps you determine the radial and ulnar extent of your incision, it can also be very useful in helping determine the depth. As you can see, within the wound, the Palmaris Longus will be sitting within the radial extent of your wound. Just beneath the Palmaris Longus will be the parallel to your incision fibers of the transverse carpal ligament. Note that these fibers run perpendicular to the Palmaris Longus and, as I mentioned, parallel the incision. This is the fascial layer that you'll proceed with your surgical technique. It is useful to place the non-operative hand underneath the patient's hand and your thumb at the distal end of the transverse carpal ligament. The wrist is best placed in a position of neutral to avoid causing increased pressure or decreased space within the carpal canal. When clearing the synovium on the undersurface of the transverse carpal ligament, it is important to start at the most proximal portion of the fascia and insert the synovial elevator along the path of the scope. When inserting the scope, it is important to place the tip of the scope underneath the fascia. At this point, one should redirect their attention to the camera to ensure that you are following a path directly along the transverse carpal ligament. Before proceeding and raising the blade, you will always want to make sure that the scope is in line with the radial border of the ring finger. When inserting the blade assembly into the carpal canal, it is important that when the blade assembly is inserted, that upward pressure is directed to keep the scope and blade assembly as close to the undersurface of the transverse carpal ligament. This allows you to ensure that no extraneous tissue gets placed between the blade assembly and the transverse carpal ligament. Once you have appropriately inserted the blade assembly and aligned it with the radial border of the ring finger, the next step is to determine the distalmost extent of the transverse carpal ligament. This is important to ensure a complete distal release. Your first guide is your thumb, which you have previously positioned at the end of the transverse carpal ligament. This serves as a tactile stop. You also have visual cues. As you look toward the distal end of the transverse carpal ligament, you will also see that there is a difference as you move your thumb up and down in terms of the stiffness of the tissues. The stiff tissue constitutes the transverse carpal ligament. The looser tissue distally is distal to the transverse carpal ligament. Sometimes this is not as obvious a distinction as you see right here in the inset frame. When you have difficulty determining the distal extent of the transverse carpal ligament, it is very reasonable to simply retract the scope proximally and pick a point proximal to the distal extent of the ligament. Begin your distal release here by inserting the blade and retract. As you can see, there is still continuity of the transverse carpal ligament distally. You can then easily work your way distal, taking multiple swipes until you get to the distal end of the ligament. As you can see here, the distal extent of the ligament has been completely released without any risk to distal structures. It is important that you have verified the release of the distalmost extent of the transverse carpal ligament prior to releasing the proximal extent of the transverse carpal ligament, because the transverse carpal ligament holds up the subcutaneous fat out of your view. Once the proximal transverse carpal ligament is released, this proximal fat can fall into your view and obscure your view. As you can see, I have released the proximal portion of the transverse carpal ligament. Now when I insert the scope, I am obscured from my view by the fat, which has dropped into my camera. This makes it very difficult, if not impossible, to further verify or work distally within the carpal canal. Once you have completed your distal release, the next step is to release the proximal portion of the transverse carpal ligament. This is often the tightest portion of the carpal canal, and it may take a considerable amount of force to retract the blade assembly. Once the transverse carpal ligament has released, this force required to move the blade assembly rapidly drops. In this case, it is very important to maintain control of the blade assembly. There are several tips for allowing you to do this. The first is to ensure that your elbow is always positioned close up against your chest wall. This will prevent you from using your biceps and powerful shoulder muscles to withdraw the scope. The second step is, as you begin your proximal release, you can move your distal hand, place your ring finger along the ulnar border of the hand, and use your thumb to push the scope out. When you do this, if the blade assembly should want to lose force and jump away from your hand, it will immediately stop, since you are pushing the blade out rather than pulling.